Hello, everyone, and welcome to this audio podcast. Audio podcast is part of the Helium space series or edition. This audio podcast is part of the Calibrated Morphology. This audio podcast is part of a Storm Robotics production. In this audio podcast, a little bit in around hematuria and the sort of indications for referral and referral between health sectors, thus referral between primary and then from primary care into secondary care. So referral depends depends on several factors, and in the peer reviewed sorry in the published works from 2015. In the published works, there's a sort of an overview in relating to some of the indications around referral, and it is important to note at the same time that all patients with visible hematuria should be referred to nephrology if if GN or glomerulonephrosis or glomerular basement membrane (GBM) is suspected, which should be established through additionally through sort of investigations such as renal biopsy. And to ensure best practice, it is important to appreciate the context in which nephrology referral is required. So in regard to some of the indications for nephrology referral initially. So, for example, suspect or high risk patients who have had sort of a urological cause excluded, or have not met the general referral criteria. Then for each potential referral to urology, a referral to nephrology should also be considered. Patients or recipients who have evidence of decline in glomerular filtration rate or estimated glomerular filtration rate, thus sort of where EGFR or GFR or EGFR is less than 10 mil per min, or just above 10 mil per min at any stage, any CKD stage, if applicable, and within the previous and within sort of a 5-year duration, where at the same time where the EGFR or GFR is sort of plus or minus sort of 10 mil per min within a previous year. So what this means, so thus means, so for example, during a typical 5-year duration, the EGFR or GFR is around 10 mil per min, or thereabouts, and then there's fluctuation between that between the sort of between a 5-year duration where the EGFR or GFR is sort of additionally plus or minus 5 mil per min within a previous year as part of a 5-year duration. And then also patients or recipients with hematuria who have stage 4 or 5 CKD, and where EGFR is less than 30 mil per min, generally is generally less than 30 mil per min. And then isolated hematuria with evidence of ABP in those less than 40 years of age, and this may be indicative of specifically around glomerular basement membrane disease or GBM disease or glomerulonephrosis, or GN, and visible hematuria matching with matching with subsequent infection, and where there's evidence of upper respiratory tract infection, upper respiratory tract infection. So in around the sort of main indications for referral, around hematuria evidence. So number one, evidence of visible sort of macroscopic hematuria, which would be a general issue. This usually requires sort of a fast track urology referral for imaging and cystoscopy, unless strong pointers to acute renal disease or nephrology specialist. Unless strong pointers to acute renal disease, and referral to a specialist, to a nephrology specialist, if urological investigations prove negative. Secondly, invisible or sort of microscopic hematuria without proteinuria, where GFR or EGFR is more than 60 ml per min, and where and then and sort of additionally, and sort of a third point, patients or recipients older than 40 years with consistent evidence of hematuria, and require where there would be a requirement to be referred to urology, and recommended age, and ethnicity may vary in line with sort of urological and urological sort of guidelines and sort of indications, and also guidelines in around sort of general practice, in line to primary care, and then patients either less than 40 years of age or more than 40 years of age with negative urological investigations potentially require the same management at CKD stage 1 and 2, and where patients but it is also important to validate and screen screening results in around screening results, and screening results with imaging, with sort of radiological investigations, and patients with evidence of microscopic hematuria with significant proteinuria, or where there's albumin creatinine ratio is sort of more than 30 milligrams per millimole, or PCR polymerase chain reaction, or PCR sort of informing results of more than 50 milligram per millimole, in part of the indication, or sort of the indications, sort of documented or evidence indications around referral for hematuria, around hematuria. So that draws this audio podcast to a close. This audio podcast in around the Hilium space series or edition. This audio podcast as part of a calibrated morphology, and this audio podcast as part of a Storm Robotics production.